most deadly,
Rare.
very rare, very rare. We talk about thyroid lymphoma. Of course, thyroid lymphoma is uncommon to the thyroid, and it doesn't originate, in the thyroid gland. Okay, so less than 5% of the malignancies as well. Okay, primarily the non-Hodgkin's type is the type of lymphoma that is cancerous to the thyroid. Primarily the non-Hodgkin's type. Patient with thyroid lymphoma actually have pre-existing Hashimoto's. Right? What's Hashimoto's again? Hypothyroidism in 90% of the cases. Okay? And again, sorry ladies, I should have just kept copying and pasting this. More common in females. That's what I mean. That was weird. That was kind of contradictory about the book. Is that when you give the criteria that who more likely to have cancer, it says males, but in neither of the cancer cases it says all of them are women are more likely. But that was I need to look into this book. Look into this book. Thyroid lymphoma is going to be a large hypoechoic mass. Doesn't that sound just like medullary? Doesn't that sound just like papillary? Right? So that's what I'm trying to get to you guys, is that these cancer cells are very, very, very similar. These masses, they're very, very, very similar in appearance. Okay? But you just have to test those cells, right? Or do the FNA biopsy to evaluate those cells. Okay? Significant because it's going to have areas of cystic necrosis when we talk about thyroid lymphoma. We're going to have areas of cystic necrosis when we talk about thyroid lymphoma. It should have been good. Who laughing that hard? Thyroid metastasis, not a common site for metastasis. Usually, if something metastasizes to the thyroid, it's going to be later in the disease process. Okay? It's usually not one of the primary routes or sites of metastasis. Okay? When it's found, it's usually from melanoma, the breast cancer, renal cell carcinoma, or lung cancer.
So that's the areas that they go to want to metastasize?
Yeah, they're coming from those areas to the thyroid.
Oh.
Coming from those areas to the thyroid. Okay. It is a solitary, well-defined hypoechoic nodule or diffuse gland involvement. Like this right here. Diffuse gland involvement. Okay. But it has no distinctive sonographic features. I can't eyeball this and say, oh, that's lymphoma. Oh, that's papillary cancer. Oh, that's medullary cancer. Oh, that's follicular cancer.
And
So that's why I'm keeping the images to a minimal, because if I show you an image, it's going to be strictly on memory. Or that was under the section of blah blah blah, right? I can't eyeball this and say, oh yeah, that's for sure. That's this, and this.
On that one, since you wouldn't see the borders, where did you measure?
Well, on this one, this is transverse, right? So of course I would start the measurement right there, but I would maybe, use a different, like a lower frequency transducer, so I can cover more area and measure that mass. Remember, like I said, if the thyroid happens to be bigger than 6.5 centimeters, then it's not going to fit on the 12 transducer anyway. Mm-hmm. So if I just need to measure that mass, then I'm just going to use my curve transducer to measure that mass, or use a lower frequency transducer. I don't know. You may have a linear 8 there. It may be big enough to see that. But I need to use a transducer with a larger footprint to where I can get all of this information, like the curve transducer. Like I said, it's just going to be for measurement, not for getting the details of that actual mass itself. You got me?
So where does the mass start, like from the lateral side?
So this is the actual thyroid right here, and this is neck. So I don't know. It's like it starts right here outside, but I don't know. It may be a connection to the thyroid somewhere. On this image, I really can't say. But this huge mass, remember, it's met. So it's traveled to this area. It's traveled to the area it's in. Goodness, my house is going crazy. So I can't see the far lateral borders of this mass
Can
itself.
you use panoramic picture to measure?
Huh?
If the transducer is small, can you use panoramic?
You can if you have a steady hand. You can use the panoramic, but the thing about doing panoramic on a structure that's round is that it's hard for it to be accurate. It has to be a structure. Most of the time, you use panoramic on a structure that's flat because it's going to be easy to glide across it. When you have something that's round, it's gonna appear round on the screen, and sometimes it won't track it accurately. Just in my experience of using panoramic. Okay? I usually like to use it on something that's flat, you know. But you know, again, if this isn't like a palpable mass where it's protruding out of the neck, then yeah, I probably can use it because the skin surface would be flat. But if it's like a nodule, it's bumpy on my neck, then it wouldn't be a good candidate to use a panoramic on that.
Hernia? Can you use on hernia? Hernia?
What's that?
Hernia.
A hernia? Yeah, you can use it on a hernia. You can use it on a hernia. You know, I would actually like say, for instance, like if say for instance it was above this, it was making the skin protrude. You can use a standout pad. You can use a standout pad, and because that's going to give you that flat surface. If you just want to cover that area, you know, yeah, you can do that too. But like I said, you can use the panoramic, but I would probably use a curved transducer to get the accurate measurement. Okay, then I would come back, maybe use a panoramic. Like me using panoramic depends on the situation. Like if I have the opportunity, like, oh yeah, let me use this panoramic and sagittal and transverse. It just depends on, you know. But like you say, if I can, I'm going to try to get the doctor all the information I can. All the information I can. Okay. So, guys, those are our cancers right there. Okay. Papillary, follicular, medullary, anaplastic, lymphoma, and metastasis. What's that? Oh, I thought you said something. Those are cancer, guys. Do you know those the things highlighted in blue about them? Okay. We know that the key points about each
It's
one.
a lot of blue.
It's a lot of blue? I didn't realize that. Know those most common things about them, though, for sure. Okay? So, parathyroid glands, I kind of just covered the most important things concerning the parathyroid glands. Okay? Here goes parathyroid glands right there. Okay? Talk about parathyroid embryology. So, the parathyroid glands are derived from the endogerm cell tissue in the embryo. They begin as separate paired glands, meaning the two upper glands are paired, the two bottom glands are paired. Okay? The superior parathyroid glands develop in the primitive pharyngeal region. Okay? And they migrate to the upper portion of the thyroid gland. Okay? I think it says in the book the third what is it saying there? What is it saying in the book? The third pharyngeal something or other. Right? No? Huh? It says both in the book. Anyways, I thought y'all read it.
Third new pouch.
The third pouch.
Yeah.
That what you said? So okay. Yeah, the third pouch of the superior parathyroid glands, and they migrate to the upper middle portion of the thyroid gland posteriorly. Okay, so they don't start with the thyroid; they're going to migrate there. Okay. Same thing for the inferior parathyroid glands. They develop in the thymus gland actually, but they also come from the fourth pharyngeal pouch. Okay, and they migrate inferior dorsal area of the thyroid. Okay, just like our picture right here. Our superior parathyroid glands, our inferior parathyroid glands. Okay. To our anatomy. Okay. So normal migration occurs in 60% of the patients, meaning that 60% of the patients, their parathyroid glands are in the right position on the thyroid. Okay. The other 40%, you're gonna have ectopic locations for your parathyroid glands, usually submandibular, okay, in the mediastinum, retrotracheal and intrathyroid, actually inside of the thyroid gland itself.
40%.
Huge percentage, right? Huge percentage.
So they stay inside themselves.
Again, I don't ever remember a case of me actually seeing parathyroid glands unless there was like a parathyroid adenoma. These are also endocrine glands, guys. They're located on the posterior surface of the thyroid, and most people have 4, but some people may have 3 to 5. Okay? Usually have 2 superior and 2 inferior, and these are small, flat, and disc shaped. Okay? They're very, very small, 5 millimeters in length, 3 in height, and 1 millimeter in width. Okay? 5 by 3 by 1, very, very small. When you think about detecting something on ultrasound, this is 0.1 centimeters. You know what I mean? That's
so small.
That's so small that if you don't know, how to look for them, and because their echogenicity is very similar to the surrounding structures in the neck, that's why it's difficult to see them on a plain scan because of that size. So some laboratory data, guys. Parathyroid glands are considered calcium sensing organs of the body. Okay? They produce parathyroid hormone. They produce parathyroid hormone to control serum calcium using a feedback system. Okay? So they kind of communicate with blood and bone, telling them to give out calcium into the blood for absorption. Okay, so that's what they secrete. They want calcium in the blood, but we know that the thyroid that secretes the C cells secrete calcitonin. If there's too much calcium in the blood, then that's going to enact that particular hormone. Okay, so they're kind of going to work hand in hand in that way to keep the calcium regulated in the body. So when the calcium levels decrease in the body, the parathyroid glands stimulate and release PTH. Okay? That's going to act on several target organs like the skeletal system, bone, the kidneys and intestines to increase calcium absorption in the blood.
Positive feedback.
Positive feedback system. So again, PTH secretes parathyroid hormone that regulates the serum calcium in the blood. Sonographic evaluation, guys. Normal gland measures 5 by 3 by 1, which is very, very small, and the echogenicity is very similar to that of the thyroid. Very, very difficult to distinguish sonographically. Exclamation point. You won't see those guys in normal anatomy. All right, be careful. Don't mistake this for the longus coli or a minor bundle of mass in the neck of in the neck itself. All right. Pathology and pathophysiology. Okay. So there's 4 pathologies associated with the parathyroids. One is going to be hyperparathyroidism, which is a common endocrine disorder, meaning that your body secreting too much PTH, right? Usually caused by a single parathyroid adenoma, which is why adenoma is a subsection of hyperparathyroidism. Okay? And that occurs in 80 to 85% of the cases. Parathyroid hyperplasia and 1% is carcinoma. It affects those 40 to 60 years of age. One thing I want you to know for sure is that primary hyperthyroidism is characterized by excess secretion of parathyroid hormone, and is usually caused by a single parathyroid adenoma. Okay? Those are the 2 things I want you to know about hyperparathyroidism. Okay? An adenoma, of course, we know it is a benign lesion. It's the most common cause of hyperparathyroidism. All right? Hypoechoic, homogeneous, and solid masses. Okay? And possibly enlarged extrathyroidal feeding artery. Meaning when you turn the color Doppler on, you're going to see an enlarged artery feeding that particular adenoma. Okay. Guys, these right here, these are different nuclear medicine scans, nuclear medicine scintigraphy. Okay, and remember I said that's like the gold standard for testing thyroid function itself, is using nuclear medicine. Alright, and here's a parathyroid mass. Looks like one could be, this is superior inferior mass. Inferior mass, right? Because this is a thyroid right here, superiorly, and you have the inferior adenoma of the parathyroid gland right there. Okay. So this is a sagittal image, right? Sagittal image. And those are kind of the areas you want to look for them. Posterior, superior and inferior to the thyroid. Same thing right here in transverse. Same thing right here in transverse. Posterior, not to be confused. If you're on the left side and you see this, don't confuse an adenoma with the actual esophagus, right? Because on the left side, that's about the area where the esophagus kind of lays. So, you know, be careful to not confuse the two. Remember, the esophagus has that target appearance.
Or you can ask the patient to swallow.
Yeah, you can do it. You can read it. Yeah, you can do that. You can do that. You can do that. Okay, and this is the left side right here, and you can see these parathyroid. You see this, the large, it's a small gland, right? You see it has this very big feeding artery coming into it. Very big feeding arteries coming into that.